professor in the Academy of Ambulatory Foot and Ankle Surgery. I want to show you a follow-up on the procedure. This is a 1-year follow-up. So the patient had an issue where we needed to correct his bunion deformity and plantar flex his first ray, which the procedure will allow you to do, and also allows you to maintain first metatarsal length. So I'm going to show that to you right now. Okay, so our patient presented basically with a fairly significant bunion deformity, a high IM angle, but his biggest chief complaint was actually pain in the second metatarsal. Now, there's a test that I do called the Peacock Press, and in this particular patient he has a rigid rear foot and a flexible forefoot, but he also has a high CERM-PERM level of the first ray, which means he has a hypermobile first ray. In most circles we'll call this a hypermobile first ray. So he has more supination of the first ray than he does plantar flexion. So what we're going to try to do with him is correct his metatarsalgia. If we just did the second metatarsal, we'd obviously get transfer to the third. So we need to do second and third. We also need to plantar flex the first ray. And the procedure allows us to do this. So we start the procedure on the medial aspect of the foot. It's in the distal diaphyseal area. This is a percutaneous stab incision down to the bone. And then we underscore this with a small rasp. Once that is done, we place in a small Eischen burr or either a straight Eischen burr, and we make our osteotomy. This is done under the guidance of the C-arm. You can see we're placing our burr exact position on our lateral cortex, and this cut is from dorsal distal to medial proximal, and we also cut it in an angle so that we don't get shortening of the first ray. And also there's a little maneuver at the end where we leave a little lateral plantar shelf, which allows us to plantar flex the first ray. So there's our cut after moving it over slightly lateral there. And then we also did an Aiken procedure on this particular patient as well, just to make him have a straighter toe there. And this is our K-wire fixation. This is a fairly unstable osteotomy because it is in the diaphyseal portion of the bone, and it will require stabilization or fixation. I use a K-wire and I use a cam walker. If you're going to use just the K-wire, you would need to double pin the K-wire, but a combination of the cam walker and the K-wire fixates this osteotomy pretty well. That shows the placement of the K-wire, and then we start our metatarsal osteotomy the second here. We did osteotomy the second and third mets as well. So here's this pre-op X-ray. You can see a fairly high IM angle. It has a prominent second and third ray, so we're going to do osteotomies on that. Here's an immediate post-op. This is, well, actually not immediate. This is 3 weeks later, right before we pulled the K-wire. And this is a photograph I really want you to see. After we pulled the K-wire, and we got some healing there. If you look at the first met, look at the amount of plantar flexion we're able to achieve. And there's a cortical shelf there that'll all kind of heal back in. And here we are later on. That's 6 weeks later. You can see our osteotomies of the second and third beginning to heal, and our Aiken beginning to close in, as well as the some secondary bone healing in the first ray. And then finally, here we are at 1 year later. You can see our osteotomies have healed fairly well. Aiken's healed, the first ray is healed, and our second and third metatarsal have also healed. This is the lateral view 12 months later. You can see in this lateral view we have complete consolidation of our osteotomy, and we achieved a fairly good amount of plantar flexion of the first ray. So now we're going to switch over and go to the portion of the video where we're going to let the patient tell you how he does. This is more of the testimonial portion of the video. Good morning, I'm Dr. Peacock. I'm one of the professors in the Academy of Ambulatory Foot and Ankle Surgery, and our organization promotes minimally invasive foot surgery throughout the world in both the podiatric and orthopedic communities. I want to show you a follow-up for a 1-year follow-up on the PRIV procedure, and that's the acronym for the Peacock, Revered, and Eischen Bosch procedure. And that's a bunion surgery. It's good for plantar flexing the first ray and for taking care of fairly large IM angles. It's done minimally invasive, and we've had a publication on this. Let me show you this patient 1 year later and just go over a few things with you. When he first presented to me, he had a lot of trouble with a bunion deformity, and he had a lot of pain under the second metatarsal. Now with his foot type, this is very important. If you place him in root neutral position, he has a rigid rear foot. He has a very flexible forefoot, but in his first ray, he had a high SERM, in other words, a high supinatory end range motion as compared to his plantar flex, or the pronation end range motion. So he has a high SERM perm level, also known in some circles as a hypermobile first ray. So, when we're trying to address his second metatarsal pain, it would not be very well just to do a second met osteotomy, because it would transfer the pain to the third or even to the fourth. So with him, what we did, we followed the Levington outline, and we did osteotomies on his second and third metatarsals, because his pain is most in the second. But we also want to take care of his bunion deformity, and we wanted to plantar flex the first ray. So now if you look at his range of motion in the first ray now, it's equal, and actually has probably more plantar flexion than he has supination. So we're able to plantar flex this first ray utilizing the MIAA procedure, which is a minimally invasive surgery we do from a medial approach in the lateral diaphyseal bone here. It's an oblique cut through and through, which allows plantar flexion by maintaining a plantar lateral shelf. Now I'm going to show that to you in more detail. But the main reason we're showing you this is the follow-up for 1 year. If you look at the bottom of his foot now, the IPK is mostly resolved, and he's not having pain anymore. So we're going to talk to the patient now. This is 1 year status post MIAA procedure. Bobby, let me ask you this. I know when you came in, you were having a lot of pain with your foot. If you had to rate your pain in your foot from 0 to 10, 10 being the worst, what do you think it was when you came into me a year ago?
About a 9.
About a 9. So you were having a lot of pain with your foot. So he was having quite a bit of pain. Now we're 1 year later, and how much pain do you have now?
I don't feel nothing now.
So good, everything's gone. So you're able to do what you want to, and are pain free. So that's what we're trying to do is to eliminate pain in this patient. And you have to examine the foot, and foot typing is very important. For example, if we had this same foot type and we had a flexible rear foot, you have to address the rear foot or your work in the forefoot will not work as well. So in those types of patients, we would do a hypercure to stabilize the rear foot before we even start our forefoot work. So the nature of this video is to kind of tell you the importance of the foot typing before you do the surgery, and also what you need to, how you need to manipulate your surgeries to make them work. And some of these patients that have metatarsalgia, they will normally have a rigid rear foot and a flexible forefoot. And then there's going to be a subset, they're going to have a rigid rear foot, flexible forefoot, and a high SERM perm level. In other words, they're going to have a hypermobile first ray. That's going to have to be addressed, which we did in him, and it's the reason why his pain is gone.